Now we'll go to the symposium for infections and diabetes. I would like to call the chairpersons, Dr. M.C. Deepak, Dr. Dharmarajan and Dr. S.S. Murthy on the stage.
Let us quickly move on to the next session. That will be on infections and diabetes. So to talk on the first topic, MDR tuberculosis and diabetes, I would like to call upon Dr. Narasimhan from Apollo Hospitals. Welcome, sir. MDR tuberculosis and diabetes, we all know the association. It has been convincingly shown that diabetes is an independent risk factor for the development of MDR tuberculosis, especially primary MDR TB. So to talk on the subject, I would like to call upon Dr. Narasimhan.
Good morning to all of you. At the outset, I'd like to thank Dr. Vijayakumar for having invited me to share some of my thoughts on this multi-drug resistant tuberculosis and diabetes. I'm extremely happy because I have not given this talk even in pulmonology conferences. It's one of my favorite topics. Years back, I'm reminded that I sent an article on convergence of two epidemics, tuberculosis and diabetes. Some 25 years back when I was studying the unit in Jipmer, it was actually bluntly refused. Many times the paper went and came back for corrections, and that time the diabetology field was not there. It was only physicians and pulmonologists, and the paper was refused bluntly, and I'm very happy. And now 2 years back there was a paper from Lancet on the same topic, convergence of tuberculosis and diabetes epidemics. My talk would be more on tuberculosis and diabetes, and with some touch on MDR tuberculosis. I won't be touching on any of the clinical aspects or the drugs and so on. So one has to know, if one has to know about tuberculosis and diabetes, one has to get a good knowledge of the double burden of TB and diabetes mellitus. What's the effect of tuberculosis on diabetes? Most of the textbooks which I read, the book that we read when we were MD postgraduates were K.N. Rao's tuberculosis. K.N. Rao's article on TB and diabetes is he wrote on tuberculosis, how it affects diabetes, and diabetes, how it affects tuberculosis. That's how he used to write the articles. His chapter contained that. And now we also like to know about, one has to know about the incidence of tuberculosis and diabetes, which is extremely important for us, because in patients with tuberculosis, one has to look for diabetes. Which group of patients is what I will be touching upon. Similarly, if you diagnose diabetes, one should screen also for tuberculosis. Which group of patients should be screened for tuberculosis? Radiographic findings of patients in diabetes mellitus. We all know that diabetes mellitus and tuberculosis, you have more often the lower field tuberculosis, that rather the predilection for lower zones is more common, or the predilection for upper lobes is lost. You get more cavitating diseases in diabetes. It's very important for us because when you have a patient with diabetes in whom there can be a weight loss, TB patients also can have weight loss. When you have a bilateral lower zone disease or a single lower zone disease not responding, one has to think in terms of tuberculosis. Severity of the disease and outcomes in patients with diabetes and tuberculosis, which worsens, whether TB worsens diabetes or diabetes worsens tuberculosis, one has to keep in mind, which means it is the responsibility of both the diabetologist and the pulmonologist and the ID specialist to treat all quite effectively. Does TB lead to diabetes? There used to be a concept some time back. There are some papers from Nigeria and South African countries where they said tuberculosis predisposes the patients to diabetes. It makes, like gestational diabetes, they do develop GI glucose intolerance, and then after the treatment is over, they have found that there has been a reversal of the diabetic status. They just maintain at their at a pre-diabetic level, they maintain their HbA1c levels, and also the pharmacological issues in patients with tuberculosis and diabetes mellitus. So the link between the diabetes mellitus and tuberculosis has been recognized for centuries. Even in pygmies, these pyramids, Egyptian pyramids, they found the PCR test and found that there was tuberculosis in patients who had low lung tuberculosis. The bacilli were found in them, and even in Vedas they have described tuberculosis as one of the diseases. Shivsutas has described eloquently about tuberculosis, and also the link between the diabetes and TB has been described. And it's also recognized that diabetes is an important risk factor for tuberculosis and multi-drug resistant tuberculosis. It's because the multi-drug resistant tuberculosis is slightly more in diabetes compared to the normal population, because in diabetes mellitus, the TB bacilli can multiply quite well, quite extensively they can multiply. And so the bacillary load is extremely high. When the bacillary load is extremely high, you do have resistant mutants. We know that if the bacillary load is quite high, there can be one mutant that can be present. That mutant can outgrow the population. And if you have the large number of bacillary population, as happens in diabetes, you can have rifampicin resistance, INH resistance, and so on. Multi-drug resistance can occur. TB worsens the glycemic control and worsens diabetes. So that's the reason why we keep insisting that the control should be quite robust and quite tight. Glycemic control has to be maintained, otherwise the disease can worsen, the TB can worsen and the diabetes can worsen. And the bacillary population grows more, and as I said, and more the bacillary population, we know the calculation wise, if the sputum contains 10 to the power of 6 bacilli, there can be one INH resistant mucus. If you have 10 to the power of 7, there can be streptomycin resistant. 2 mutants can be there. If it is more than 10 to the power of 8 per ml, you can have double MDR rifampicin INH resistant mutants can grow, which means as the population grows, the bacillary population grows, the chances of one getting a drug resistant tuberculosis is pretty high. What actually is drug resistance? The drug resistance is when a microorganism changes in ways that render medication that used to cure infection, they cause ineffective. The presence of drug resistant strains result from simple Darwinian principle brought out by the presence of antibiotics. That is, if the antibiotic is there, and for example, if there are 10 to the power of 4 bacilli, and if one is exposed only to INS, single drug treatment, if we give INS kills only those INS sensitive bacilli, the resistant bacilli are remaining, they start growing and they outgrow the population of sensitive bacilli, and the resistance starts. The multi-drug resistance results from stepwise accumulation of individual elements. It's because MDR occurs when one starts adding one drug to a failing regimen. You must always add 2 drugs to a failing regimen. And MDR regimen, there should be minimum of 4 drugs, 4 to 6 drugs you must have. If you add one drug to a failing regimen, the chances of developing drug resistance is pretty high. Hence, MDR TB is a man-made catastrophe. So there are 2 kinds. One is primary drug resistance, other is acquired drug resistance. Primary drug resistance, right from the word go, the patient has. We do come across in our days, when I was doing my PG course, we were told that primary drug resistance is uncommon. We don't find primary drug resistance at all. But nowadays we do find primary resistance also in one of the patients, because the number of population of MDR is going up and the chances of getting infected also is pretty high. So that's why in a population, or if a patient has an index case of MDR tuberculosis, and if someone else develops a tuberculosis in the family, we try to screen them for MDR TB. Gone are the days. In our days, we had a big study, Hong Kong BMR study, where we said one need not do a culture study at all per patient. We did a study and found that if a patient culture positive, do the culture sensitivity studies, and without smear positive itself start them on treatment. We compared and found that there was no great difference at all, because they were the days when resistance was not there. Now the days have changed. With the HIV, with the increase in diabetes mellitus, with the increase in NCDs, definitely we are going to see more and more of MDR tuberculosis. And acquired resistance is one where, because it's a man-made thing, that inadequate dosage, inadequate timings, and the patient doesn't take the drugs because of the side effects, or he has been told that one need not take it, or diabetes is not properly controlled, and he is told to take insulin, he doesn't take insulin, he goes back to the physician who tells him that not to take insulin, you can handle glycemic control well with oral hypoglycemic agent. These are some of the causes for the acquired resistance. So what are the types of resistance that we have? We have a mono resistance, single drug resistance. Very commonly we find nowadays INH. We never used to find like that. Nowadays, in the last 6 months, we are saying INH mono resistance. So where do we fit in? We say MDR means we can say rifampicin INH. Multi-drug, we can say that. XDR, we can say. Total drug resistance, we can say. But INH mono resistance is playing a major role, because it is a bactericidal drug which acts on both group A and group B populations, and mono resistance adds a very big problem to the management of tuberculosis. Polyresistance, we know it resistance to all the drugs. Multi-drug resistance is rifampicin and INH. Extensive drug resistance, and TDR is total drug resistance. Monodrug resistance to single first-line ATT, INH, or polydrug INH or rifampicin. Polydrug resistance to 2 or more first-line ATT except MDR. MDR TB strains with resistance to both first line drugs, rifampicin INH, that's one of the biggest problems that we face is a lab diagnosis. XDR TB is strains with MDR plus resistance to any of the fluoroquinolones, plus resistance to at least one second line injectable drug, amikacin, kanamycin and capromycin. We call it as extremely drug resistant tuberculosis. This is going to be one of the big problems again, because we do use fluoroquinolones quite extensively in our country, and if you have a patient of chronic acute pneumonia and if that turns out to be tuberculosis, and especially in patients with diabetes mellitus, when you have a bilateral horizontal disease, you start these patients on quinolone, there is a chance that if that turns out to be tuberculosis, you are likely to have a patient with an XDR tuberculosis, which is quite difficult to treat. And TDR TB is total drug resistance. The road is closed completely for them. There are no drugs at all available for these patients. Resistance to all first line, all MDR, all things can be a problem. It's going to be a very big problem. So which means MDR, XDR and TDR are going to be big problems, and this commonly occurs in situations where the bacillary population can be extremely high, and that very commonly happens in diabetes mellitus, which makes them prone for these diseases. So in other words, the drug susceptible tuberculosis was the one. That's the days when we were doing post-graduation. We used to see more of drug susceptible tuberculosis only. We could start the patients on INH. We used to tell there is no difference in treating patients of diabetes mellitus with TB with that of tuberculosis with any other normal individual. But gone on in 1990, when we completed our post-graduation and started becoming staff, we found that MDR tuberculosis used to be extremely rare. We used to tell drug resistance is not that infective. Actually, we presented a paper from our own college saying drug resistant patients don't infect that fast. It is the smear positive. Drug sensitive tuberculosis is much more infective than a drug resistant tuberculosis, but now the days have changed. Now there is an incidence is increase of multi-drug resistant tuberculosis, and XDR TB is now was identified in 2006. Now we have total drug resistance. So it means the problem is growing gradually. Tuberculosis control is becoming a mirage. So in conclusion, I must add, does diabetes, there are a lot of questions to be answered with diabetes and tuberculosis. Though we know everything about diabetes, we can send him to a diabetologist who can tell everything, who can manage, handle diabetes very well. Similarly for tuberculosis, we know we can make a diagnosis quite very well. We also know the drugs that we can treat for tuberculosis, but there are a lot of misgivings, but if the combination occurs, there is always a problem. Does diabetes leads to increased susceptibility of initial tuberculosis infection? That if the patient is negative, he is MAN2 negative or completely negative, naive patient, if the patient has diabetes, say for example, insulin dependent diabetes, do they become infective very fast? Do they become do they convert MAN2 converters into very fast do they get converted? Does diabetes increases the progression of latent TB to active disease? If the patient has a latent TB, that is the patient is MAN2 positive or IGRA positive, all these things, pulmonologists and ID people will never start these patients on tuberculosis. But if the patient is diagnosed as an IGT or if he has a diabetes mellitus, does he need to be treated? We get referrals from Shankar Nethalya, ophthalmology. They have to be started on steroids for an eye problem. So when you started on steroids for eye problem, when you do a MAN2 test, if you have a pulmonary opacity or a parenchymal opacity or a fibrotic scar, it makes us wonder, by giving these patients steroids, if this patient has an IGT, increased glucose tolerance, will he be prone for tuberculosis? We start these patients on chemoprophylaxis. If that be the case, if he doesn't have eye problem, you make a diagnosis of tuberculosis. And should these patients be screened for tuberculosis? Would screening for a latent TB in recently diagnosed diabetes mellitus useful, or is it cost effective? If yes, in which population should we do that? Because the priority in our days, WHO's priority in our country for tuberculosis is to see that we treat only patients. We don't bother about latent tuberculosis infections. Chemoprophylaxis was never a part of our RNTCP. So we always say treat the patients. If trying to diagnose or screen tuberculosis patients and find out latent, that money can be spent on treating patients with tuberculosis. That used to be the refrain of most of our RNTCP program. Though WHO says that you must go for this treatment or latent diagnosis of latent tuberculosis infection. In diabetes, it holds good because of the increased incidence of MDR and XDR. One has to be very, very careful in trying to screen this patient. Which TB patient should we screen for diabetes? On the same score, if you diagnose tuberculosis in an old patient, extensive disease, we should screen these patients for diabetes, and which group of patients should be screen for tuberculosis. Does diabetes prolong sputum positivity and culture conversion? One of the biggest problems, we expect the sputum to convert in within a month's time. It should become non-infectious in 15 days, convert it 1 month's time, and then culture should become negative. All these things we give in a stepwise pattern in a non-diabetic patient. Even diabetes, does it cause a delay? If that show relapse, it will be more common because relapse occurs with drug susceptible bacilli only. Would MDR be more common? I have mentioned the reasons why MDR can become more common in diabetes because of the increasing growth of the bacillary population, fast growth of the bacillary population. MDR would definitely be there. Is pharmacodynamics the cause for MDR? If so, should we routinely monitor the drug concentrations? Is mortality high in diabetes? If so, who are the patients at risk? And these are the things should be monitored. With increasing rates, my last slide, with increasing rates of obesity and NCDs, there is bound to be an increase in TB, and the end TB strategy of RNTCB may be a distant dream. Thank you very much for your patience.